Welcome. Let's talk about severe sepsis and septic shock, the 6-hour bundle now. So earlier we spoke about the 3-hour bundle. We've covered that early recognition of severe sepsis and septic shock, identifying the source along administration of antibiotics and IV fluids. So now let's talk about the 6-hour bundle. So first few things we need to cover is one is the reassessment of the volume status in the patient and tissue hypoperfusion. You want to look at vital signs to see whether they've improved, see whether the MAP, the heart rate have improved with fluid resuscitation. The other ways of assessing as well as urine output, assessing to see whether it's more than 0.5 mils per kilogram per hour. Another way of assessing fluid status as well is to look at the tissue perfusion in terms of capillary refill. So cap refill is another useful way of assessing that. And one of the other ways as well is to repeat a lactic acid level. So if you had done it initially, the repeat lactic acid may give you an idea whether there's improvement. You generally try to look for at least a 10% improvement of it reducing as a gauge on whether you're moving in the right direction. CVP monitoring was pretty popular previously, and it's not so much more, and the reason is that it's pretty much useless unless the value is low. So unless it's a low value of less than 8, a value of a normal or above that, it's hard to gauge whether the patient is going to be fluid responsive or not. So that's why it's kind of gone out of vogue. Another way of assessing fluid responsiveness is going to be a bedside echo, and I urge anyone who's thinking of going to pulmonary and critical care, for example, or intensive care, to equip themselves with bedside echo knowledge as well, because that's a great tool to use at the bedside for dynamic assessment. So during the 6-hour window, now you have to assess and see whether your initial attempts to resuscitate the patient have shown improvement or stabilize the patient. So you're looking for, like I'll repeat myself, lactic acid. You're looking for changes or improvements in your vital signs, for example. You're looking for signs of improvement in tissue perfusion by way of looking at the urine output as well. So these are some of the measures, and like I said, the CVP or even echo at bedside will give you an idea whether your resuscitation has been adequate. Now let's talk about a few other things as well that go along with a lot of patients who are in severe sepsis and septic shock, one of it being central lines. Now most of the time, you have to understand that central lines don't save lives. They're a great way to deliver fluids, deliver sedatives, medications, and so on, but they don't save lives. So don't distract yourself by taking up more time to put a line in instead of thinking about which antibiotics are appropriate or giving IV fluids quickly. Now, if you can't get a peripheral IV line, for example, a 16 gauge or an 18 gauge, and the patient's crashing, placing a femoral line, there's no harm in that. Another great tool to use is an intraosseous device. So apart from a central line like an IJ, intrajugular, you can also use an intraosseous device, and if you're in the ER doctors are pretty good at that, so you can get that placed pretty quickly. Again, don't distract yourself if you can't get a central line immediately. If the patient get a good peripheral, that will work just as well. The next thing is vasopressors. There's a few that you want to use or use frequently. One is norepinephrine. Norepinephrine is preferred over, I think I just spelled that right, I hope I did. Norepinephrine is preferred over dopamine, as dopamine is found to be more tachyarrhythmic and actually is increased mortality in some subset of patients. So norepinephrine is your first line. If that doesn't work, then consider epinephrine as an adjunct to norepinephrine. Now, if you still need another pressor as an adjunct, vasopressin works pretty well. It should not be used as a sole pressor, and it shouldn't be titrated. You can either use 0.03 or 0.04 units a minute. And so you have your vasopressors such as Levofed or norepinephrine. That's your first line. Epinephrine as your second line. Third is vasopressin. And if you really can't, as salvage therapy, you need to use neosynephrine. But don't use neosynephrine otherwise, because it basically acts as a pure alpha constrictor. So all it does is clamp down the vessels, and if there's any suspicion that you have cardiac dysfunction, you actually impose more stress on the heart. I understand that sometimes there's a worry about tachycardia and so on, or tachyarrhythmias from Levofed, But usually, and most of the time, the tachycardia is driven by the septic shock itself. So the shock itself drives tachycardia. So it's not a medication effect. It's more the pathophysiological effect of the shock itself. So I understand that there's a concern for it, but don't let that don't let that stop you from giving Levophed or norepinephrine as a first line. The next thing I consider as well is, while I'm trying to resuscitate the patient with IV fluids, make sure you give them at least 30 cc's per kilogram. And then what I want to do is, you want to always resuscitate and reassess them. So after giving at least 30 cc's per kilogram, which generally for most patients it's usually the third liter of fluid, I then start adding on albumin. And I tend to give this as albumin 25%. It's 100 cc's, Q6 to 8 hours. This is a great adjunct to use so that you do give that expansion without giving as much volume in these patients. But I generally, like I said, you can add that on to your normal saline or LR or lactated ringers that you're giving. Another pet peeve of mine is this hesitation of giving fluids in patients with a diagnosis of heart failure. Now, if they're not manifesting signs of decompensated heart failure, you shouldn't stop yourself. It shouldn't stop you from giving IV fluids, because the shock is going to kill them first, especially if you suspect them to have septic shock. If a patient's intubated, then you have to worry even less. At times, I may be cautious, especially if they have an EF, or I know they have an ejection fraction of, let's say, less than 20% or less than 25%. I know that their heart failure is actually pretty bad. I may bolus them at 500 cc's at a go instead of the full 1000 cc's that I normally do. But this requires you to assess the patient more frequently to see whether they're alright. If I give the 500 cc's, I need to follow up to see whether they are decompensating, whether they develop crackles in the lungs. And at times, if you need to intubate someone because of volume resuscitation is necessary, go ahead and intubate them. The next thing is what's recommended by the Surviving Sepsis Campaign guidelines, as well as a CRP and a procalcitonin level. I use this to great use pretty frequently, especially I get that on the front end and on the back end. It helps me decide at times, especially in patients that I'm concerned that they may not be in septic shock or severe sepsis. There may be other causes for their shock. This helps me break the deadlock at least. And on the back end as well, after the first few days in, as I see the procal trending downwards, you will have patients that end up having a bump up in their white cell counts, or even having a low grade temperature. So in those patients, you really don't know whether it's a new infection, whether it's more of a non-specific finding. A procalcitonin at that point, especially if it keeps moving the wrong direction, may suggest the patient has a new hospital-acquired infection, and that may increase my suspicion to increase maybe reculture them and so on. Hydrocortisone is another hot topic. I generally tend to get, my personal flavor is that I generally tend to give it if they're unresponsive to IV fluids and they're on vasopressors, and usually not low dose vasopressors, usually increasing vasopressors. So I feel like I'm slipping down a slope and the pressors need to keep going up. At that point, I add on 100 IV hydrocortisone, Q8 hours. Now, I know the recommendation generally is no more than 200 milligrams, but I generally just give 100 milligrams Q8 hours IV hydrocortisone. The recommendation as well is to give continuous infusion. However, most of the time, the reality is that continuous infusion does take up a lot more IV lines. And the hyperglycemia is something that's really problematic to deal with as well in patients that receive the Q8 hours. So take that as well into consideration. During the 6-hour window right now, once you work the patient up, you started them on fluids, you started them on antibiotics, whether they're on pressors, whether you put a central line in at that point. The next thing to do is reevaluate if you haven't found a source of the shock. So source control is going to be important. If you need to step it up by getting a CT abdomen pelvis because there's still no source of the shock, or reevaluating and re-examining the patient one more time to make sure that there's no other source of the infection, that will be prudent and really appropriate at this point. A bedside echo, like I mentioned earlier as well, will be a good way to gauge and see whether your improvement in terms of their fluid resuscitation. And if the patient's intubated, follow general ventilator setup, which I spoke about in a previous video as well. You want to target 6 mils per kilogram tidal volume, especially if you have someone in ARDS. Thank you.